Hi, this is Dr. Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy Prostate Cancer Series 101, video number 1 on PSA testing and diagnosis of prostate cancer. So let's get started. So prostate cancer is the most common cancer in men aged greater than 50 in North America. In the U.S., about 288,300 new cases a year and about 34,700 deaths. That's for 2023 estimates each year. And in Canada, about 25,000 new cases a year and 4,600 deaths are likely each year. The incidence increases each decade of life. Autopsy studies show prostate cancer in 15 to 60% of men, age 60 to 90. So let's talk about PSA, or prostate-specific antigen. Pardon me. So with prostate-specific antigen, there is not really a normal PSA level, but there are ranges that we consider normal for different ages. So for ages 40 to 49, a normal range would be 0 to 2.5. For ages 50 to 59, 0 to 3.5. For ages 60 to 6.9, 0 to 4.5. And for ages 70 to 79, 0 to 6.5. And this is because as we age, our prostates tend to get larger, and therefore with more cells produce more PSA. So that's kind of a typical normal ranges that we expect. So PSA is a test that we can do to hopefully find early prostate cancer in men. However, I just want you to be aware, in the U.S. we have this group called the U.S. Preventative Task Force, and they recommend what screening tests people should obtain in order to prevent a significant disease like cancer. And so I want you to be aware that for prostate cancer screening, for men aged 55 to 69, which is, those are some peak years for prostate cancer in men, it says the decision to undergo periodic prostate-specific antigen, or PSA testing, should be an individual decision. Before deciding whether to be screened, in other words, before deciding to even get the test, men should have an opportunity to discuss the potential benefits and harms of screening. In other words, the benefit and harm of screening with their clinician, and to incorporate their values and preferences in the decision. Screening offers a small potential benefit of reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening, including false positive results that require testing and possible biopsy, overdiagnosis and treatment complications such as incontinence and erectile dysfunction in determining whether this service is appropriate. So that's for ages in men 55 to 69. So a pretty lukewarm suggestion that men should get tested. And in men 70 years of age and older, this CRAC Preventative Services Task Force recommends against PSA-based screening for prostate cancer in men 70 years and older. So I'll leave it to you to decide, but do you trust these people? So when we have an elevated PSA level, which I hope all men are getting checked for that are of the appropriate age, if the PSA level is elevated in those age norms, a prostate biopsy might be recommended. So normally the prostate is about the size of a walnut or a truffle, as you see depicted here. And then what the urologist is going to try to do is basically sometimes like a needle in a haystack. It's gotten better since we have the use of ultrasound now, but they're trying to take biopsies from all the quadrants of the prostate using an ultrasound device in order to find where the nodule might be and hopefully catch in one of their biopsies where prostate cancer might be lurking. To help with that, there's also MRIs of the prostate now, and so that stands for Prostate Imaging Reporting and Data Systems, called PIRADS. And if you see in an APS a description of PIRADS 1 or 2, you can ignore that as not worrisome. However, if the PIRADS is 3 to 6, you may want to postpone until subsequent biopsy is completed and rate per the biopsy results. And this is from our Optimum manual. Prostate intraepithelial neoplasia, or PIN, or ASAP. And what are these actually in regard to? So, prostate intraepithelial neoplasia, or ASAP, which is a typical small acinar proliferation, you can kind of consider this as a in situ kind of suggestion of a pre-malignant lesion in the prostate. PIN1 is low grade, PIN2 or 3 is high grade, and it may be abbreviated HGPIN, or then also ASAP is noted here in the table. When you get to the higher levels of PIN, or you see the biopsy report as ASAP, you may want to take notice, and then we have instructions on how to handle those particular findings. And this again comes from the Optimum manual. So when you're going to do a biopsy, here's what the biopsy gun looks like. It's a spring-loaded biopsy gun, and you can do the biopsy with one hand, which is useful because the other hand of the urologist is probably doing something else that's important, holding the ultrasound or something along those lines. So when this spring-loaded biopsy gun, when you hit the button, it sounds like a gun going off, which is somewhat disturbing when you're the patient and you're getting the biopsy done. So here's what's going on. So in order to get the biopsy, you have to go through the rear end and through the rectal mucosa to get the biopsy from the prostate, because there's no other good way to get there. And you're also using an ultrasound probe in the rear end to try to distinguish where the lesion is in the prostate, as the bottom picture on the left depicts. So you see the probe of the ultrasound, and you see the biopsy needle in order to get the biopsies from a lesion that might be detected. And to the right, if the red circle was the cancer, what you want to do is insert the needle, then fire it. The needle goes through the cancer, comes back through it, and then a piece of tissue is extracted into the needle, and then you pull the needle out. And you do that maybe 12 times in different parts of the prostate, and especially where any nodule is observed with the ultrasound, in order to get tissue to look at under the microscope to see if there's prostate cancer present. And then you get these thin little tiny strips or fragments of biopsy material, and the pink would be regarded as normal prostate tissue, and those darker purplish cells are actually prostate cancer. So that's all you get. So you have to make a diagnosis based on that. It's not easy to do. So sometimes it requires the expertise of people in tertiary care type places that have specific labs that look at prostate pathology on a regular basis in order to give a second opinion on whether they think prostate cancer is present, and if so, what is the grade of those cells. So, it's hitting a tiny target in the prostate, and you can imagine, I'm using food to demonstrate here, that when you stick that needle in to do a biopsy, it depends on what angle you're shooting from and what you're going to get. And prostate cancers are not necessarily all nice round lesions, but maybe strips or in a roll or a flat area. Or so it's kind of like trying to hit the olive in a pimento loaf, or shooting it through a cake roll. Depends on what layer you get through is what you're going to get. So you're hitting a tiny target in an organ that's not necessarily cooperating with trying to get the right tissue that you're looking for. So prostate biopsy interpretation of those thin strips, as shown at the bottom, again, are difficult to interpret. Some pathologists are better than others, and prostate biopsy may be understaged. So it may be read as a Gleason 3 plus 3 equals 6, when really it's a Gleason 3 plus 4 equals 7. And it's just due to the expertise or the lack of expertise of the person reading the biopsy. Johns Hopkins has an excellent pathology team. It's a great place for second opinions, and they're happy to look at slides from anywhere for a price, which is reasonable, to help assess whether a person has prostate cancer, and if so, what is the Gleason grade. So just a joke, what do you call the doctor who graduated last at the bottom of their pathology training program? You call them a pathologist, right? So what's this Gleason score business? That's Dr. Gleason up at the top left, who this is named after. And I put a honey baked turkey to the right at the top because that's what we're going to do if the prostate is removed, say, at surgery, and you get to use the whole prostate and slice it up and look at it under slides to determine what the final cancer grade is. So you look at each slide, whether it's a biopsy or the path report from a removal of the prostate. You look at the architecture of the cells, and Dr. Gleason drew pictures similar to the ones in color at the bottom. His were just in black and white, but these are in color. And the grade in Gleason went from pretty normal looking cells that are enumerated 1 to the most common finding, which are kind of in a yellowish color. That's Gleason 3. And then the cells really start getting wacky looking in 4, and then definitely in 5 looks more like a Salvador Dali picture. So those are the Gleason scores when you look at a slide that has the prostate tissue when prostate cancer might be present in the biopsy. So you look at all your slides and you look for, first, the most common pattern in all your slides. So when you look through the slides, does it look like 3 is the most common pattern, or 4 is the most common pattern, or 5? Then you go through the slides again and you look at what is the second most common pattern. Is it still 3? Or would you say, there's some 4 over here that I also noted? Then what you do is you add up the most common finding, most common number first, so the Gleason grade of the most common noted pattern first, so that would be 3. And then you add plus whatever the second most common is. So if it was 3 was really the most common when I went through the first time and also the second time. It's really a 3 plus 3 equals 6. But what if I went through and 3 was the most common on the first pass, but I noticed some 4. So that would be a 3 plus 4 equals 7. Or what if I went through the first time and it was mainly 4, but then I saw some 3 also, but in a smaller degree? Then that would be a 4 plus 3, but also that equals 7. So when you get a Gleason 7, you have to figure out, is it a 3 plus 4, which is actually better than a 4 plus 3? And the reason I had the ham up there is when you get the whole pathology specimen, you slice up the whole thing and make a slide out of each slice. Hopefully you're not having it for any holiday dinners coming up soon. So with prostate-specific antigen, just to review this again, the hazards of using it is, we used to say that 4 was normal, and if it was above or below 4, we made our determination on that. But as I said, there are age ranges that help us determine when to get biopsies if that may be needed. And what we measure PSA in, which I have at the bottom of the slide, is nanograms. So if you get a 4, that's 4 nanograms, which is 4 billionths of a gram, which is a pretty tiny amount. So because we're dealing with such tiny amounts of PSA in the blood, the variability of a result is about 10%. So a 4 is really somewhere between 3.6 and 4.4. That's how much variation there is due to the tiny amounts of PSA that we're actually dealing with. So what about BRCA and prostate cancer? You've probably heard of BRCA1 and BRCA2. Everybody has BRCA genes. So women and men have BRCA1 and BRCA2. However, some people have a mutation in their BRCA1 or BRCA2 genes, and they have a higher risk of developing prostate cancer. And the cancer may be more aggressive. So men that are BRCA1 or BRCA2 positive, and that's due to BRCA1 or BRCA2 mutations, so they don't have a normal BRCA1 or BRCA2, they're at risk for cancer at a higher rate, and it may be more aggressive. So something to keep in mind if you see somebody has a BRCA, a male, and they have a history in the family of prostate cancer. At the bottom, I also wanted to note, and I put it in red, that even in otherwise favorable appearing Gleason 6 cancers, they should not be treated with active surveillance if BRCA mutations are present. So it would not be a good idea to use active surveillance if a male has BRCA mutations and they had a Gleason 6 on their biopsy specimen. Also, family history is very useful in determining whether somebody's at risk for prostate cancer. If a man has a first-degree relative, like a father, son, or brother, who had prostate cancer, they're twice as likely to develop prostate cancer, and the risk increases with the number of affected relatives, and it's 5 times for men with 2 relatives and 11 times for men with 3 relatives. So the risk goes up with these strong family histories of prostate cancer. In family histories of prostate cancer, it's not necessarily that the cancer is going to be more aggressive, but it may occur at younger ages. So you may want to do testing with PSA at earlier ages in the subsequent generations of men in that family. So here's an interesting factor. So I had a brother-in-law who was 56 years old, and he had a PSA of 3.9. So His MD said it was below 4, so she said to him, no problem, it's below 4, 4 is the magic number, so you're okay, no problem. So he asked my opinion at a Christmas holiday dinner, and I said, well, for your age group, using ranges for your age, I would say that 3.9 is actually high for you. So I would recommend a biopsy. I don't want to disagree with your doctor, but you asked, so I'm telling you, I think a biopsy would be useful. So he had a biopsy and the prostate cancer was found. So he had a radical prostatectomy and did well, and no subsequent recurrence or any problems following that. So he had 2 brothers. So one of his brothers went for a PSA check after this, and his PSA was elevated. So he had a biopsy, and he had prostate cancer and had appropriate treatment. So then his other brother said, well, I better have a PSA check as well. So he went and had a PSA check. His PSA was elevated, so he had a biopsy and cancer was found. So you can see that these things run in families, and so good to keep an eye on things, especially if there's a family history. So what are the downside risks to prostate biopsy? So, it's definitely not something pleasant that anyone wants to repeat if they can avoid it. There may be minor complications such as rectal bleeding, blood in the semen, blood in the urine, difficulty urine, and discomfort at the biopsy site. Sometimes, on rare occasion, you can actually, because you're going through the colon to actually do the biopsy, you can actually, when you click the gun to get the specimen, it goes through anything that's in the colon which may be carrying bacteria, and it deposits it in the prostate, and you can actually get sepsis. So if somebody has a prostate biopsy and then has high fever and chills, they should see their doctor immediately. You should avoid strenuous activity for 3 to 4 days after the biopsy, so no jogging, bicycle riding, strenuous activity like that. Avoid intercourse for the next week. And you may notice if you fly in an airplane after a recent biopsy that when you get to your destination, you're peeing blood, so something to be aware of. And let's say you have a positive biopsy and your doctor recommends surgery. You actually have to wait 6 weeks for that area in your prostate to heal where the biopsy was done before the surgery can be done, which is, that's a difficult time. You're sitting around waiting for 6 weeks for your body to heal so that you can have major surgery and then have to heal up again after that. So what are some tests that are confirmatory to help in the diagnosis with prostate cancer? So there's this small MP capital MRI, or multi-parametric magnetic resonance imaging, and it's basically taking extra pictures when they're doing the MRI to hone in on areas in the prostate. So it's kind of like a juiced MRI to take more and better pictures using advanced imaging technology to hopefully detect and assess for prostate tumors if they're present. There's also other tests like the prostate cancer gene 3 or PSA3 test, and we're going to talk a little bit about these tests. And then there's something called the Prostate Health Index. So you may come across any of these things in the medical records when you're looking at a case where testing was done to look for prostate cancer, or if a biopsy turns out to be positive. So in addition to a PSA test, there are some other tests that are possibly done. Well, we talked a minute ago about the PSA3. That's done in the urine. if the test result is greater than 35, it helps you determine whether to biopsy or not. So that's one test that you may see. There's also a test called the 4K test, is also used to biopsy or not, and greater than 7.5% probability of aggressive cancer if that is, considered positive. Epi switch gives you a high versus low probability of cancer, so you may see that test done. And then there's something called the Decipher genomic classifier. That gives you the likelihood of metastasis in the next 5 years, and it's scored from 0 to 1. So this PSA3 is a prostate cancer antigen 3, which is mRNA, is a biomarker that is tested in a urine sample. It has increased specificity for prostate cancer compared with PSA testing alone. And so it's thought that the use of these biomarkers can reduce the number of, in parentheses, unnecessary biopsies. And it's described as where PSA is a glycoprotein that may enter the bloodstream. PSA3 is a gene that exists in the nuclear material of the prostate epithelial cells that may be shed into the urine. And so a score of 35 or higher is considered, they call it optimal, for diagnosing prostate cancer, while a score lower than 25 may indicate pathological indolent prostate cancer. This 4K test that I mentioned is also a test that may be used, and you may see a result of that. And it's after an abnormal PSA and or digital rectal exam, a DRE, to assess your probability of finding aggressive prostate cancer. Using prostate-specific biomarkers may help. And so the 4K score of 7.5 or higher may indicate the need for a prostate biopsy. A 4K score of 5 or lower is associated with a decreased likelihood of a Gleason score of 7 or higher on a biopsy. So another test that urologists may recommend to help in the assessment, going forward. So this 4K score, why is it called 4K? And it's because it incorporates a panel of 4 kallikrein protein biomarkers, which include total PSA, free PSA, something called intact PSA, and human kallikrein-related peptidase 2. So those are the 4 Ks. That's why it's called the 4K score. And other clinical information in an algorithm that provides a % risk for high grade or Gleason 7 or greater on a biopsy. So this is additional information about what the K4 score is, which you can review. It's indicated for use in men 45 years of age and older who have an abnormal age-specific total PSA and or abnormal DRE or digital rectal exam prior to the first biopsy or after a negative biopsy. So that may be used to help aid in the decision for an additional prostate biopsy. Then we'll talk about the Decipher prostate genomic classifier. Sometimes it's just called Decipher, and it's used to determine how likely the patient's cancer is to metastasize within the next 5 years. And so at the bottom, it's described as a biomarker that outperforms the standard markers like PSA level. It looks at the activity of 22 genes in prostate tumors, and it calculates a score from 0 to 1. So the biopsy report may look like this. To the left is the report if you have a biopsy done. To the right is if you have a radical prostatectomy. So It depends on whether you're looking at a tiny biopsy and that report, or you're looking at the whole prostate removed in the RP report. And these are the additional pages you get on the report, depending on if it's a biopsy or the total removal of the prostate. So it helps tell you, if this might be an aggressive type tumor, and gives you information to help you make decisions in that regard. The last one I'll mention is called the Switch prostate screening blood test, and it's 5 epigenetic biomarkers, and it shows, or the studies that use this show how your behaviors and environment can change the way your genes work, and does that put you at risk for prostate cancer using these particular biomarkers, and it's used alongside of standard PSA testing. So you may see that somebody is in the red with a high probability of increased risk, or in the green with a low probability of increased risk. So there's lots of tests to aid. There's a new one which I added at the bottom in purple. I think it may be spelled wrong there, but I think it's My Prostate Score 2.0, abbreviated MPS2, and it tests for 18 genes. So you can refer back to this, but all these tests may be used in some form or another to help determine whether the person may be at risk for whether they need another biopsy, or if they've had a biopsy, how risky is the biopsy result they have, and are they at risk for metastatic disease. So that completes the first video in the Optimum Academy 101 on prostate cancer. Stay tuned for our video number 2.